Everyone, welcome to my channel, and in this video I'm going to cover biliary tract related disorders. So to begin with, I'll be talking about cholecystitis, cholelithiasis, choledocholithiasis, and cholangitis. To keep it straightforward, sometimes these can be mistaken and quite confusing. So cholecystitis is basically the infection or inflammation of the gallbladder. Cholelithiasis is a gallstone within a gallbladder. A choledocholithiasis is a stone within the common bile duct, and a cholangitis is infection or ascending infection of the bile duct. All right. So let's start with cholecystitis. So what is cholecystitis and how do we define cholecystitis? So cholecystitis is an acute inflammation of the gallbladder, okay, often in the setting of a gallstone or biliary sludge. So that is defined as a cholecystitis. Now cholecystitis are two forms. It could be acalculous cholecystitis or calculous cholecystitis. Acalculous cholecystitis is commonly seen in very ill patients and is associated with a very high mortality. What happens in these patients is that gallbladder goes in stasis, or probably there is hypoperfusion because of hypotension and infections. So these are the common etiologies that results in an acalculous cholecystitis in very ill patients. Okay, versus a calculous cholecystitis is basically a gallstone which impact within the opening of the common bile duct. So of the gallbladder. So it can lodge here, or it can be within this, resulting in inflammation. Okay. So it is very commonly seen in females. Now the reason being, if you remember from the USMLE step 1, the 5 F's, fat, female, 40, flatulent, and fertile. Okay, so those 5 are basically, 5 F's are the common risk factors associated with a cholesterol gallstones. Okay, so gallstones can form because of these reasons. In addition, hormone replacement therapy, obesity, hypertriglyceridemia. Okay, now these impacted stones can also result in infection, and the common bugs associated with cholecystitis is E. coli, Enterobacter, Enterococcus, and Klebsiella. Okay, so EEEK bugs. These bugs can infect gallbladder, and so you need to be specific when choosing your antibiotics against cholecystitis. So the pathogenesis is that this is the cystic duct. If a stone is lodged into this, it can lead to distension of the gallbladder, resulting in inflammation and infection. So this is basically the pathophysiology associated with cholecystitis. So how does patient presents? Patient presents with fever, chills. These are systemic signs because of infection of the gallbladder. Now, what is very specific is the right upper quadrant pain that may radiate to the shoulder. This is a classic presentation for cholecystitis. Then, on inspection, jaundice typically not seen. This is very important. Sometimes the liver enzymes, the GGT, the alkaline phosphatase may be normal. Okay, so you do not expect jaundice in cholecystitis. On palpation, the patient experience tenderness in the right upper quadrant. All right, and when there is tenderness on palpation, the right upper quadrant, and in addition, there is arrest of that inspiration with palpation of right upper quadrant, that's the Murphy sign. So this is a classic test or a sign that is significant for cholecystitis. In addition, there's another sign called Boas sign, where a patient experiences hyperesthesia to light touch in right upper quadrant or infrascapular area on the right side. Okay, then moving on to the studies, the diagnosis. So how do you diagnose? So you are always asked in the exam what would be the best initial test. Definitely, because you want to do an ultrasound of the right upper quadrant. That would be the best initial imaging in case of cholecystitis. Okay. So what do you want to look for in the imaging studies? You may find a stone, you may find biliary sludge, or there may be a thickening uh, of the gallbladder wall. Now, what is classic is the ultrasonic Murphy sign. So when you press, or when you put the probe on the right upper quadrant, patient experience pain. So that is what exactly ultrasonic Murphy sign is. Now, if the imaging on the of the ultrasound is not apparent, all right, but you have a high apparent for cholecystitis, but you have a high suspicion, uh, then you can do a HIDA scan. All right, a HIDA scan will show you a lack of gallbladder visualization, meaning that there is an obstruction. Okay. Not always you do a CT scan of abdomen and pelvis in case of a cholecystitis. The only reason you do a CT scan is to rule out other abdominal pathologies, or the presentation may be atypical. So that is when you do a CT scan. All right. Sometimes it may show abscess or pericholecystic fat stranding. All right. So maybe some other pathologies might come up on the CT scan when the presentation is atypical. So you do the liver function test, you do basic simple CBCs. What you find is that the labs may be high or normal. Okay, so this is very important in case of cholecystitis. Your labs might come back normal. However, your white blood cell may be slightly elevated because of infection associated with cholecystitis. Your CRP might be high because of some sort of inflammation going on. All right. So those are some indication. So what is the diagnostic criteria for cholecystitis? This is all you want to know. So there is local inflammation. Your physical exam, your history is very important in this case. Murphy sign, right upper quadrant tenderness, along with systemic inflammation that may come up as fever or high white blood cell count, and the imaging with the ultrasound may show you a cholecystitis. Okay, so what does the imaging shows? So when you do a gallbladder, so this snap shot is from USMLE UWorld QBank. And here, if you see, the diagnosis of acute calculus cholecystitis is typically confirmed when right upper quadrant ultrasound reveals colitis with gallbladder wall thickening or sonographic Murphy sign. So these are very classic presentation on the ultrasound. Okay, if ultrasound is negative or inconclusive, then you may go with HIDA scan, and the nuclear medicine test has a sensitivity and a specificity of more than 90% for acute cholecystitis. Great. Now that we have done the diagnosis, let's hop on to treatment. So how are you going to treat cholecystitis? Cholecystitis, always patient presents with pain, right? So your first address, how do you address in the beginning? So the first thing you should address is the pain. If the patient is dehydrated, you want to hydrate the patient, all right? Give analgesics and correct the electrolytes. So basically, the first line treatment would be supportive care, all right? And in addition, you want to start off with IV antibiotics specific to these bugs, which is EEK bug, E. coli, Enterobacter, Enterococcus, and Klebsiella. So IV antibiotics. And then non-emergent cholecystectomy. This is very important. Usually you get a question on these steps saying, when would you have this patient for they give you the diagnosis of cholecystitis, acute cholecystitis. So when are you going to operate the patient? You want to operate the patient during this hospital stay or after 6 to 8 weeks. Your answer must be this hospital admission, all right? Because non-emergent cholecystectomy means the cholecystectomy must be done within 72 hours of presentation, all right? Much sooner cholecystectomy or emergent cholecystectomy is indicated in case of generalized peritonitis or perforated cholecystitis or gangrenous cholecystitis. So those are the first line management. If that is not possible, let's say the patient is medically unstable, then percutaneous drainage. This percutaneous drainage is indicated in patients who are very ill. Patients might, have an acalculous cholecystitis. That is when you do a percutaneous drainage. Okay. So next up is this. So again, this is from UWorld, and so how would you manage a patient coming up with an uncomplicated gallstone? So a gallstone on imaging without symptoms, you do nothing, okay? No specific treatment necessary in most patients. What if a patient comes with a gallstone on imaging with typical biliary colic symptoms? As we said earlier, acute pain management, then prophylactic cholecystectomy, which has to be elective, it's not emergent, but within 72 hours of hospital admission. All right, and possible UDCA. UDCA is ursodeoxycholic acid. The mechanism of ursodeoxycholic acid is that it melts the gallstones. Okay, so this can be considered in poor surgical candidates or patients who are refusing surgery. All right, then gallstones with atypical symptoms. Now this is very crucial. Now these atypical symptoms may be something else. So you want to evaluate for other causes. Or you may also give a trial of UDCA. All right. If patient improves on UDCA, then you may consider a cholecystectomy. This piece of information, this one in red, those who present with atypical pain may not need HIDA as a presentation may be from other pathology. Okay, this piece of information is from a recent published paper. So any patient who has atypical symptoms, we might think, and who has a gallstone, okay, you don't need to do a HIDA scan, okay? You probably might do a CT scan to know other etiologies, but a HIDA is definitely a no, okay? Then how about patients who present with typical biliary colic symptoms without gallstones on imaging? Now this is a trivia. Now here what you do is basically you do a HIDA scan, okay, with cholecystokinin stimulating simulation. So you give CCK along with HIDA scan, okay? So why do you do this? You want to evaluate for functional gallbladder disorder. So there's no stone, but there is typical biliary colic symptoms. So you do a CCK with HIDA. The reason why you do this is you want to know the ejection fraction of the gallbladder. Okay, so here is a note on functional gallbladder disorder. Functional gallbladder disorder is diagnosed based on Rome 3 criteria. Okay, so here the patient presents with episodes of pain in the right upper quadrant or epigastrium, and all of the following may be present. Okay, so gallbladder is present, normal liver enzymes, conjugated bilirubin, amylase and lipase, pain which lasts for more than or equal to 30 minutes. Recurrent episodes occur at different intervals, not daily. This is important. Pain builds up to a steady level. Pain is severe enough to interrupt the patient's current activities, and pain is not relieved by bowel movements, postural change, or antacids. Other structural diseases that may explain the symptoms have been excluded. So that's a functional gallbladder disorder. So when you do a HIDA scan with CCK, you're basically measuring the ejection fraction. So if your ejection fraction of the gallbladder is less than 35, this is an indication for cholecystectomy. Like how this says, you do a cholecystectomy in patients with a low gallbladder ejection, which is less than 35%. Okay, so this is about functional gallbladder disorder, and in addition, we have spoken about the management of uncomplicated gallstones. So we have completed the presentation, the definition, the etiologies, the risk factors, the studies related to cholecystitis, and now we will move on to the complications related to cholecystitis. So cholecystitis can cause ascending cholangitis, okay? And there might be a gallbladder perforation resulting in a gallbladder ileus, gallstone ileus. Then post-cholecystectomy syndrome. Now these are broad disorders. In post-cholecystectomy, there might be small stones that may be dislodged in the common bile duct that may result in persistent pain after cholecystectomy. Okay, so that could be one presentation. All right, other may be a functional dyspepsia. All right, patient may present with a constant epigastric distress or postprandial distress. All right, or sometimes patients present with diarrhea. Okay, so we will speak in detail about those. Okay, so what's post-cholecystectomy syndrome? It occurs after cholecystectomy, presents with right upper quadrant pain, increased AST, ALT, and alkaline phosphatase. So if you have a small stone, for instance, lodged in this common bile duct, you expect ALT and AST along with alkaline phosphatase to increase. Okay, so what you do then is an ultrasound and an ERCP. ERCP is both diagnostic and therapeutic, and if you find any stone lodged in the common bile duct, you can easily remove it. Okay, so this is why you do ERCP and ultrasound in case of, if you suspect post-cholecystectomy syndrome. So the pain associated with post-cholecystectomy syndrome is usually either due to sphincter of Oddi dysfunction or post-surgical adhesions. Okay, as I said earlier, some stones or biliary microlithiasis, some stones might be, might remain in the common bile duct that can result in pain. Sometimes functional dyspepsia, which presents with the epigastric tenderness, that may be treated with proton pump inhibitors or dopamine antagonists, or sometimes tricyclic antidepressants. And lastly, sometimes patient may present with diarrhea. Now, this diarrhea is in post-cholecystectomy syndrome is a type of bile acid diarrhea. Let me explain this with the help of a question which is from UWorld. So, a 58-year-old obese woman comes to the physician with a 6-month history of intermittent postprandial colicky right upper quadrant abdominal pain. Each bout of pain lasts about 15 minutes, and the patient has a 10-year smoking history and alcohol, and parents died of heart attack, and we will skip this. And palpation of the abdomen shows tenderness in the right upper quadrant. Murphy sign is present. Abdominal ultrasound reveals several gallstones and biliary sludge. Now the patient undergoes uncomplicated laparoscopic cholecystectomy. Great. Then on a following a follow-up visit 2 months later, she complains of daily diarrhea. Now she has tried dietary changes with no improvement. What is the next step in management? You start with cholestyramine. Cholestyramine is basically, these are bile acid sequestrants. Cholestyramine, cholecipol, or cholecalcivilam. These may be started in patients who do not respond to dietary change. Okay, so how does this help? Let me show you about this in a cartoon form. So what happens is you remove post-cholecystectomy. Now you remove the gallbladder. So a lot of primary bile acid, which has been prepared in the liver, now moves on to the second part of the duodenum. Okay. Now the bacteria converts the primary to secondary bile acids. Now, uh, these bile acids are stored in the gallbladder. Okay, not all, a lot, because the gallbladder is absent, a lot of primary biliary acid is being secreted into the duodenum. Okay, so there's a lot of bile acids, now secondary bile acids within the intestine. Now this bile acid, secondary bile acid, moves into the colon, right? Now this is excess. This excess secondary bile acid causes colonic contraction, all right, and that results in diarrhea. So how do you treat this? You treat this with bile acid binding resins called cholestyramine. So this is cholestyramine. What does it do? It sequesters these bile acids or bile salts. Okay. So when it does that, the colonic contraction reduces and the diarrhea also reduces. So this is how primary bile acids or primary biliary acid binding resins like cholestyramine help prevent diarrhea in patients with post-cholecystectomy syndrome. Okay, so so that was all about acute cholecystitis. Thank you very much, and please subscribe to my channel and hit the like button. Thank you so much.